In this video, we're thinking about the reversible causes of cardiac arrest. And this is very important to know about for two reasons. The first is, if a patient is in cardiac arrest and that cardiac arrest is not amenable to normal electrical defibrillation as normal, then we need to think about these reversible causes during the cardiac arrest event. But as well as that, if we know the reversible causes of cardiac arrest, we can think about how to prevent these in the first place, and ideally to prevent cardiac arrest from occurring in the first place, because of course prevention is always better than cure. And what we're thinking about here is the 4 H's and the 4 T's. 4 H's and 4 T's. Think about these to prevent cardiac arrest in your patient, and think about these if a patient is not responding to normal defibrillation or are in a rhythm that is not amenable to defibrillation, such as pulseless electrical activity or asystole. And all the time in a cardiac arrest, it's important to realise that basic life support must never be interrupted. So the 30 to 2 must always be ongoing. The 30 chest compressions to the 2 ventilations. That's the only way the patient's brain is being kept alive. It's the only way the myocardium and other vital organs are being kept alive. We don't want that to be interrupted. So let's start off by thinking about the 4 H's. These are hypoxia, hypovolemia, hyperkalaemia and hypothermia. Now the hypoxia first of all. Hypoxia can cause cardiac arrest. So in a patient who's at risk of hypoxia, we want to treat that hypoxia as soon as possible in order to try and prevent a cardiac arrest from developing in the first place. So for example, a patient with a severe asthmatic attack may become hypoxic. If we can treat the asthmatic attack at an early stage, then hopefully we can prevent that patient deteriorating. And if a patient is already in the cardiac arrest situation, we need to reverse the hypoxia before the heart will start. And the old saying is, blue hearts don't start. So the blue here, of course, is referring to cyanosis. So if the patient's cyanosed and systemically hypoxic, the myocardium is going to be as well. And that means it's not going to respond to normal resuscitation attempts. We must first reverse the hypoxia. So make sure the patient is well ventilated, give them as high flow as oxygen as we can get. We're aiming for oxygen saturations of 94 to 98%. Make sure the patient's well ventilated, and in the hospital situation we'll be using airway adjuncts such as a Guedel airway or an iGel, or ideally endotracheal intubation with full oxygenation and ventilation depending on the skills that are at your disposal at the time. So we need to reverse the hypoxia first before the heart will restart. We need to take time to do that while carrying on with the 30 compressions to 2 ventilations. So hypoxia is the first H. The second H is hypovolemia. If the blood volume is very low, then the blood is not going through the coronary arteries and the myocardium is not being perfused with blood. And we need to make sure the myocardium is properly perfused to get the nutrients to the myocardium, to get the oxygen to the myocardium, and of course to remove the waste products of metabolism from the myocardium. Now, hypovolemia in the cardiac arrest situation normally is caused by hemorrhage, because this is the acute situation if a patient loses a lot of blood all of a sudden. And the rhythm that the patient will tend to go into is this pulseless electrical activity. Now in pulseless electrical activity, when you put on your ECG leads, you can still see a rhythm, and it may look like a normal sinus rhythm. But because the myocardium is not getting any blood supply through the coronary arteries, the myocardial cells are unable to respond with their contraction. The myocytes will be acontractile. and the heart will not be contracting, even although there's electrical activity going on for some period of time. It's pulseless electrical activity. So this is, as we say, most commonly caused by hemorrhage. It could be a massive gastrointestinal bleed. It could be a ruptured aortic aneurysm. Or more commonly, perhaps, we see it in the acute trauma situation, where the patient loses a lot of blood. So we want to prevent as much blood loss as we can from our patients, obviously with good first aid measures. And we want to think about the normal bleeding situations, that blood can be lost onto the floor and form more. External hemorrhage onto the floor, into the thoracic cavity, into the abdominal cavity, into the pelvic cavity, or through the long bones. And basically we need to stop the hemorrhage. We need to try and fix the leak and give back fluids and give back blood. And we also might want to consider tranexamic acid, which can sometimes be helpful in the hemorrhage situation if we're not sure where the bleeding is from. Blood products are ideal if they're available in the emergency situation. So that's hypoxia, hypovolemia. And again, think about preventing hypovolemia. So if a patient's traumatised, they should be cannulated as early as possible, and the blood pressure should be controlled. We might decide to allow a certain amount of permissive hypotension. We might not want to aggressively reperfuse, but we need to try and control that situation and get blood products into them as soon as we possibly can to prevent the hypovolemia. Now, hypoxia, hypovolemia. The next one is hyperkalaemia, high blood potassium. This is often caused by what we used to call acute renal failure. We now call it acute kidney injury, but it is a failure of renal function, and the potassium simply builds up, especially if the patient's been traumatised and there's cell damage and potassium has leaked out from the cells. So hyperkalaemia is one cause, but hypokalaemia is another cause if the potassium is very low. For example, if someone's been under hemodialysis and the process has gone a little bit too quickly. So hyper or hypokalaemia. Severe hypoglycaemia is another possible cause. So again, we want to anticipate possible hypoglycemias, treating it with glucose at an early stage. If someone's unconscious in the emergency department, we'll try and give them intravenous glucose or dextrose to bring the blood sugar up. So these are metabolic disorders. Acidosis would be another one. We can sometimes get an intimation of what's going on here by the past medical history of the patient. Other times we need blood testing. And then we can go on to emergency management of the particular metabolic disorder. So that's hypoxia, hypovolemia, hyperkalaemia, hypokalaemia, hypoglycemia. We could have mentioned actually hyper or hypocalcaemia there as well, the metabolic derangements. And the fourth H is hypothermia. Now, patients with hypothermia, obviously the body temperature is low, and hypothermia just mimics death. Hypothermic patients appear, for all intents and purposes, to be dead, but they may not be. Because when the body tissues are cold, that can preserve them. The brain and the myocardium can be preserved. And the classic saying in accident and emergency departments is, no one is dead until they are warm and dead. So if a patient's hypothermic, we need to warm them up and then reassess the situation. We may warm them up and find they were in fact dead, but we may warm them up and find that they weren't. And of course, during all this time, we need to carry on with basic life support. So we can end up doing ventilations and chest compressions for quite a long time as we warm a hypothermic patient up. So that's the four H's: hypoxia, hypovolemia, hyperkalaemia, and other metabolic disorders, hypothermia. We now want to go and think about the four T's, all the while, of course, continuing with our 30 to 2. So we're now considering the four T's. and these are thromboembolism, tension pneumothorax, tamponade, and toxic substances, the 4 T's. And again, we can think about these as things we might need to manage during a cardiac arrest, or hopefully things we can anticipate to reduce the likelihood of cardiac arrest developing. So let's think about thromboembolism first of all. A thrombus is a blood clot where there is not supposed to be a blood clot. For example, in a deep vein of the leg. But the first one we're going to think about is thrombosis in the coronary artery. Now, if there's coronary arterial atherosclerosis, there's going to be coronary atheromatous plaques. And particularly inflammatory processes in these plaques can lead to plaque destabilization. And that means the thrombogenic core of the plaque comes into contact with the blood. And basically what we get then is blood clotting on the atheromatous plaque. And this is a thrombus. There is blood clotting where there is not supposed to be blood clotting. And it's this blood clotting in the coronary arteries that leads to the acute coronary syndrome. And if you get accumulation of red thrombus that can completely block off a coronary artery, this can lead to ST elevation myocardial infarction, a so-called STEMI. And if the blood supply to part of the myocardium is cut off, that part of the myocardium will start to die. And as it starts to die, it will give off very rapid, uncoordinated electrical impulses. And that will result in rapid, uncoordinated contraction of the ventricular myocardium, which is what ventricular fibrillation is. So coronary thrombosis is the most common cause of cardiac arrest, and the most common form of cardiac arrest is ventricular fibrillation. So we want to prevent myocardial infarction, of course, if we can, with all the normal preventative strategies, both medical strategies and possibly coronary angiography and percutaneous coronary intervention. But if an MI has already occurred, then urgent coronary angiography and PCI may be a possibility, but all the time we'd have to carry on with the 30 to 2, so it's quite difficult carrying on with the basic life support. But coronary thrombosis is the most common cause. Most times actually this will respond because it's a ventricular fibrillation. It's a shockable rhythm, and we would be very hopeful that that would respond to DC shock, especially if we caught it in the early stages. Now, thrombosis, we can include thromboembolism there. So if there's a thrombus in one of the deep veins, for example, that can float up the deep veins into the inferior vena cava, into the right side of the heart, and of course off to the lungs, where it can lodge as a pulmonary embolism. And a pulmonary embolism is the most common cause of obstruction or blockage to the circulatory system. And this can be a cause of cardiac arrest, because the blood if there's no blood getting through the lungs, if the blood's getting blocked in the lungs, it's not getting back to the left side of the heart, so it can't be pumped out. And that, apart from anything else, will mean that the coronary arteries themselves are not being perfused with blood because of this blockage in the circulatory system. Now, we certainly need to carry on with our 30 to 2 if we suspect this situation. But we also need to give emergency intravenous fibrinolysis. We need to give thrombolytic agents to break down the fibrin. Now, this can take a while to work. Once we give the fibrinolytic agent or the thrombolytic agent intravenously, it can take a while to break down the clot. And all this time we need to carry on with the basic life support, and this could be for 60 minutes, it could be for 90 minutes, it can be a long-term enterprise, but it's well worth doing because we do get good outcomes if we give fibrinolytics to patients with pulmonary embolism. Even if they have arrested, the outcomes can be good, so worth persevering. So that's the T for thrombosis and thromboembolism. Next one is tension pneumothorax. Now, if there's damage to the pleural membranes as a result of trauma, there can be a flap mechanism set up. And this means the air can get into the pleural space but not out. And that means the air builds up in the pleural space, compressing one lung and pushing the mediastinum across. And sometimes you can get tracheal deviation as evidence of that. And this can be diagnosed in the usual way. There can be hyperresonance on the affected side. The trachea can be pushed away from the affected side. Reduced air entry on the affected side. But basically we see this circulatory collapse, the tachycardia and the profound hypotension. Because the mediastinum is pushed across, so all of the large vessels are going to be kinked. And especially the venous vessels first will be kinked. So the venous return to the heart will basically be stopped. And the treatment for this is very often we use an emergency thoracocentesis, just a needle into the pleural space or a cannula to let the air out. And if you're right, that'll go psss as the air comes out, relieving the tension. But that will relieve the patient's symptoms really very quickly, within seconds. And what that will have done is convert a tension pneumothorax into an open pneumothorax. So we would then need to treat the open pneumothorax in the usual way with a chest drain. So tension pneumothorax as a cause, or as a treatable cause of cardiac arrest. Tamponade. Now, tamponade is pressure on an organ, and in this case it's tamponade where there's fluid accumulating between the pericardium and the heart itself. The pericardium is a rigid sac, it will only expand so far. So as fluid accumulates in the pericardium, or blood accumulates in the pericardium, it's going to compress the heart. Now, normally we would get distended neck veins and hypotension with this, but it's hard to see in cardiac arrest, so this can be difficult to ascertain if it is present or not. A good guide is the history of this penetrating chest injury that affects that area. Then the knife or whatever the penetrating object is can have gone through the pericardium into the ventricle, and blood from the ventricle or the atria can be leaking out underneath the pericardium, causing the cardiac tamponade. Quite difficult to treat. We might want to confirm the diagnosis with an ultrasound, but basically we need a cardiothoracic surgeon, hopefully to hand, who's going to do resuscitative thoracotomy to open the chest and to relieve the pressure on the heart. Without a surgical facility, these patients will probably not have a good prognosis. So that's thrombus and thromboembolism, tension pneumothorax, tamponade, thinking about cardiac tamponade, and the last one is T for toxic substances. A variety of toxic substances can affect the heart, as you wouldn't be surprised. It could be an overdose of drugs, it could be industrial toxins, it could be cyanide. Quite a few things can adversely affect and depress the heart. So what is the patient's history? What occupation are they in? Have they been taking illegal drugs? Have they taken a massive overdose of alcohol? That can cause cardiac arrest because the alcohol is a cardiac depressant. It can cause acute alcohol poisoning, can cause cardiac arrest and death, unfortunately. So what is the history? What intimates what might be causing the toxicity? But we might need blood tests. In some cases, there may be possibilities to give antidotes. If we're fortunate, there may be an antidote available for the particular substance, but very often the treatment is going to end up being supportive, symptomatic, and we would follow basic life support and advanced life support protocols. So they're the T's: thrombosis, tension pneumothorax, tamponade, toxic substances. And the aim, of course, is return of spontaneous circulation. So if we get rid of this underlying impediment to restarting the heart, sometimes we can restart the heart. But of course, knowing what we now know about the 4 H's and the 4 T's, knowing that they can lead to cardiac arrest, means that we can be very vigilant as to their presence and hopefully treat them before the cardiac arrest situation develops.